Welcome to the Naval Postgraduate School Center for Homeland Defense and Security lecture and webinar series. On behalf of CHDS and our co-hosts, the Association of State and Territorial Health Officials, the International Association of Emergency Managers, the National Emergency Management Association, the CHDS Alumni Association, and the Naval Postgraduate School Alumni Association and Foundation, thank you for joining us today. In our discussions, our panel will address the next phases of the country's COVID-19 response and how public service leaders can continue to help in this effort. Our experts will field your questions about the last mile of vaccine distribution and what the pandemic could mean for community resilience and global health in the years to come. And now it's my pleasure to introduce our moderator for today's webinar. Eileen OConnor frequently serves as a lecturer and subject matter expert on legal and communications topics at the Center for Homeland Defense and Security. Eileen is the Senior Vice President for Communications, Policy, and Advocacy at the Rockefeller Foundation, overseeing all government affairs, communications, and advocacy to advance the Foundation's programmatic priorities worldwide. She serves as a senior member of the leadership team at the Foundation and as a strategic advisor to its president. Prior to joining the Foundation, Eileen founded the Garnett Group for Public Affairs, working with clients worldwide on policy initiatives and strategic communication designed to advance and achieve their goals. For the prior 3 years, she served as the Vice President of Communications for Yale University, overseeing all aspects of internal and external communications for the university. Before joining Yale, Eileen served as the Deputy Assistant Secretary of State for South and Central Asia and as a senior advisor to the Special Representative for Afghanistan and Pakistan. Eileen, thank you for joining us today and for moderating our panel.
Thank you so much, Dawn, and thank you everyone for joining us today. You've sent in some amazing questions that I'm going to get to right after I introduce our really esteemed panelists today. Dr. Rick Bright is a member of the Biden COVID Advisory Board. He is the former director of BARDA and also the former Deputy Assistant Secretary at HHS for Preparedness and Response. He helped combat COVID and distribute the vaccine nationwide in his advisory role to the Biden administration. In March 2021, Dr. Bright joined the Rockefeller Foundation as Senior Vice President of Pandemic Prevention and Response. In this capacity, Dr. Bright leads the Foundation's work to collaborate with leading global public health emergency organizations and entities. He is developing a pandemic prevention institute that aims to avert future pandemics by identifying and responding to the earliest alerts of a disease outbreak and stopping it in the first 100 days. Dr. Bright has extensive experience in global public health. He's worked with the U.S. Department of Health and Human Services, U.S. Centers for Disease Control and Prevention, and the World Health Organization, as well as the private sector very extensively, making key advancements in vaccine and therapeutic developments for influenza viruses and with pandemic potential. And he's also helped develop new vaccine treatment and testing technologies. And we're so honored as well to have Tim Manning. Tim Manning is very familiar, I think, to many of you at the center and also in emergency response and management. Tim Manning is currently serving as the COVID-19 supply coordinator with the White House COVID response team. For more than 2 decades, Tim Manning has worked on both the front lines and in the senior-most levels of Homeland Security, crisis and emergency management, and resilience at the local, state, federal, and international levels. Tim is the former Deputy Administrator of the Federal Emergency Management Agency, Governor's Homeland Security Advisor, a firefighter and EMT, serving in both urban and rural departments and wildland interface. He's a rescue mountaineer and a geologist. Tim served through the entirety of the Obama administration as the Deputy Administrator. And he has also been having been confirmed by the U.S. Senate in the spring of 2009. And Tim, in his job right now, is going to have to leave in 20 minutes, very unexpectedly, because of a call to the White House Situation Room. So we all understand that, I know. So I'm going to really heavily start with Tim first. And I know that many of our audience really wants to know, where are we now with vaccines?
Well, thanks, Eileen. And Rick, it's great to be on the panel with you, and thank you all for taking some time today. It's wonderful to speak, and I apologize for having to drop a little early. A lot going on here. And so where we are with vaccines, what I think we're very happy to say here on day 100 here at the White House, the 100th day of the Biden administration. And we had the president initially set a goal of 100 million vaccines in the first 100 days. We hit that pretty quickly. And so he reset the goal with about 40 days left to go to 200 million, which we hit a few days back. So here on the 100th day, we're at 220 million shots given since Inauguration Day, and over 300 million doses delivered out of the vaccine manufacturing operation out into state and local governments and through all the other channels as well. The president has set a goal for originally, he's really good at setting aggressive goals, and we hit him, and then he pulls them back on us and gives us even harder work to do. So, he originally was looking for vaccine to be eligible for all adult Americans by the end of May. Well, we were there now. That gets reset. So we're now in all states, all 50 states and territories, eligibility has been brought down to everybody over 16 is eligible for a vaccine if you want one. 90% of the US population lives within 5 miles of a location to get a vaccine. And also recognize, though, that in many places, 5 miles is still a pretty good distance, can be challenging. So we're increasing every day. We look for new opportunities to bring vaccinations out to the public, everything through working with mobile centers, the work we're doing with FEMA, the federally qualified health centers, the federal pharmacy program, the work that FEMA's done to stand up the big community vaccination sites early gave a really great jumpstart to that and pushed a whole lot of activity out. And now we're at the point where we're pivoting while we're working through that, adding in channels to bring vaccines to where people are used to going. So it's going to be federal or the pharmacy program. And starting to look at getting vaccines into health practitioners and getting bringing the vaccines to the people as often as we can, while we also set up large sites so people can come to them at their convenience. I think what it's an amazing project that Rick helped kick off, that you all have been working on, that we currently have 3 highly effective, very safe vaccines in an amazingly short time, but done in a safe way, approved, reviewed, with a really heavy degree of oversight to ensure that safety and efficacy. And then it built a program that gets vaccines with an eye towards equity and delivery and gets out to the public. I think we're all very happy with where we are on the delivery. We have a lot of work to do. We still have to get to everybody who wants a vaccine and encourage those who are maybe skeptical or have some concerns or some degree of hesitation that they're safe and effective, and that we all get out of this pandemic together by getting as much uptake of the vaccine as possible.
And that's a place where local leaders can be very helpful in terms of communication, correct? Absolutely.
That communicating to the public, just like we all do this every day in our line of work, in an emergency and preparedness and homeland security concerns and pandemics, whatever it is, we need trusted voices are the ones that carry the day when we're communicating to the public. And in most cases, those are going to be the people closest to the public. It's going to be local leaders, and it's going to be people that they interact with every day. It's their doctors. It's the people that they trust, and that's who we need to work with to carry the message. That we need to work together, get everybody vaccinated to get out of the crisis.
And I will say that we've been working, the Rockefeller Foundation's been working with the federal government and actually state and local governments, as well as doing some research that was asked of us to develop some communication toolkits. And you can find those on our website, rockefellerfoundation.org. So those are free and available to everyone to use. The US Chamber of Commerce is using them, businesses and others. So feel free to distribute them to whomever. And they're backed, the communication messages is backed by a lot of research. So what about India? We've got, a huge problem in India. What is the Biden administration doing? Are you doing enough? There's been some criticism that there was some bans on things, and I think there's a lot of confusion there. And also, secondly, what is the danger of India for the United States?
Well, thank you for asking about that, Eileen. And let me start with dispelling some rumors and some misunderstanding. There has never been an export ban on the inputs to vaccine manufacturing from the United States. That has been an unfortunately persistent rumor that's been running around, not just the internet, is kind of where it got started, it's where these all get started, right? But it's been, you see it in reporting in The Economist, you see it in newspapers around the world. Unfortunately, that has gotten some traction. There is definitively, there is no export ban, no embargo, there's no restriction on the export of vaccines or vaccine inputs from the United States. The companies that are based here are exporting their product all over the world. The big constraint, unfortunately, is just it's a massively outstripped demand to the supply. The vaccine manufacturing has shifted over the last bunch of years into the heavy use of single-use products. So, bioreactor bags, tubing. It's no longer just the stainless steel vessels and stainless steel tubing that has to be decontaminated and cleaned. Think of it as, Rick would probably kill me for this analogy, but think of it as like putting a liner in your crock pot, right? Or lining your baking sheet with foil, right? The idea is when you're done, you can start over fresh. It's a really simplistic way to think about it, but there just aren't enough companies making enough of that for the global manufacturing that's needed, right? We're making on order of 14 billion doses of vaccine on top of the existing continued production. So when companies call to order these consumable supplies, these filter packs and the bioreactor bags and the manifolds and the tubing, all the stuff that goes into making that vaccine, that run, they're given really long lead times. And there's misunderstanding out there. People, most of these companies are based in the United States. So when they can't get it, it kind of furthers the rumors that there's export controls, but there's not. Just want to set that out there. But so for India, what are we doing? We've been working with the Indian government, and we have a very close relationship with the Indian government, have for a very long time. And India, I think, as has been widely reported, the president certainly says it all the time. India was one of the first to come and bring us assistance when we were going through the early stages of the worst of the pandemic. We've been working closely with the Serum Institute, one of the largest vaccine manufacturers in the world, based just outside Mumbai. We've been working with them since before their spike on helping to try to alleviate some of their supply chain issues. So, as things got really bad over the last week, we're working closely, the National Security Council and our Department of State and USAID and the whole of government, HHS, working with the Indian government to identify assistance that they need. So just yesterday, we sent two military a C-5 and a C-17 full of aid to India. They're including oxygen, some of which was donated by the state of California. So is anybody from California? Thank you for that. Remdesivir, other therapeutics, PPE, a whole list of things that they needed assistance with is being sent. We're continuing to work with them on an ongoing basis to get them the assistance they need. Additionally, we were able to, so one of the confusing facts about the notion of this export ban is that we have Defense Production Act ratings on our U.S. government contracts. All that means is that where we have a contract with a U.S. government company, if their supplier, it filters down from the company. So we have a rating, Pfizer has a DPA rating. When Pfizer needs to buy something, their contracts become prioritized over other contracts. But these companies are still selling to other people. It doesn't buy up all of their stock. It just kind of changes the order that they would fill. So what we were able to do is one of the shortfalls that they had, one of their key components of making their AstraZeneca vaccine, what they call Covishield, are these special filters from a company called Millipore based in Massachusetts. We, watching very closely our supply chain, knew that we had an order placed with Millipore for these. So we called and told them, we felt confident enough in our vaccine manufacturing and in our timelines, that told them to divert our order to India. So those filters that were coming to us are now going to the Serum Institute. They're in the air as we speak. Maybe they've landed. Hopefully they've landed. But they're en route as we talk. As we
what's
speak.
What's the danger though of the variants? We know that there was a variant that's a double mutation that we know and what we've been told is more contagious. I don't know that we know so much about it, but that it's more contagious and has caused some of the spike. But we also know it's only caused about 30% of the spike. So what are the other things that have caused this spike in India? And again, what's the danger to the United States of this spike? And number two, I know there's been travel has been restricted, but even so, what are the lessons we can take from this?
Well, yeah, I'll defer to some of that, most of that to Rick when he starts talking about some of the medicine on the variants. But I can tell you that we watch very carefully all the emerging variants, the mutations all around the world, wherever they are, and every day new ones pop up. Fortunately, we're happy to see there's increasing amount of sequencing happening. Something like 9% of all the tests are now being sequenced. So we have a higher pace of sequencing and to track these. I don't know that we have good data in yet from CDC, or at least I haven't in the last 24 hours, haven't had conversations with CDC. So I can't really speak to what we're seeing out of India as far as the variants and the increased any alterations in the spread or contagious, or whether it's escaping any therapeutics or vaccine. But the concern is, as we see what's going on there is a combination of it's multifactorial, just like every other spike, just like what we dealt with here and what we saw in Brazil and where you see these things, right? There's a combination of people letting down their guard, people thinking we're further along than we are, getting too close to each other without masks, and there's all of those things that we have been talking about for 14 months now. Always end up in a multifactorial way driving a lot of these outbreaks. The big concern for the whole world is as these outbreaks happen and it allows variants to grow, it allows things to change, it gives space and breath and fuel to the virus, all the more reason we need to focus our efforts on vaccination and slow the spread and take the air out of the room for the virus and allow us to get control of how things are moving.
So it's 2:20 and I don't want you to get in trouble. You gotta go. So
nobody wants to be that guy walking in at the
exactly.
Yeah.
So we'll let you go.
Thank you, Eileen.
I'll try to pinch hit for Tim. Tim's good to see you.
Thanks, Rick. It's good to see you too. And thank you, all of you on the call. Thank you all for everything you're doing. And it's an honor to be here supporting you for our time here at the White House. You can, most of you know how to reach me, and those who don't, I'm easily found. If there's anything I can do to support your efforts, please reach out. We're here for you. Thank you very much. Thank you. Bye.
Bye. So Rick, I'm going to put you on the spot on the India. And then I did want to talk to Tim. I know he and his team, while they're still buried in the here and now, they're also starting to lift their heads up to say, how can we do this better? And you're really steeped in that. But first, let's talk a little bit about India. What do you see as the lessons? What is the danger from the variants? And what's happening? There are states in the United States that are having surges. You're, as a doctor, what do you attribute that to? And what is the danger for neighboring states or for other places around the United States with any kind of surge, even in 1 or 2 states?
Eileen, thanks for having me, including me in this conversation. I'm sorry Tim had to go. He's such a good colleague. We've enjoyed working together as we get the Biden administration up and running and really entrenched into these areas to lead us through this pandemic, and not just the United States, but the world. You're very right, Eileen, to be concerned and ask about what's happening in India, and especially when it comes to the science and the biology, the virology, what's happening with the virus. I think the most frightening thing, or thing we should be most concerned about, is we don't have much information. We don't really have a good grasp on how prevalent many of these variants are. And when we do recognize or find one of these variants, is often 2 or 3 or sometimes 5 or 6 months after the variant has emerged and spread among the population. And then we do kind of overreact in some cases. We think it's the end of the world because we heard of a double mutant or a triple mutant or, you know, multiple mutant variant. But we don't really, at those times when we're panicking, have all the information to understand how that variant or that mutation at the genetic level translates into something impactful. We could see as viruses mutate constantly, and each time a virus goes through and replicates and multiplies in a person or a person to person or animal to people, they change, they mutate, especially viruses like the SARS-CoV-2 virus or the influenza viruses that are RNA-based viruses. So just because we see a variant doesn't mean that we should panic. The sky is not falling. But what is concerning is how little information we get and how late it comes. And in India in particular, we don't have much information on the overall prevalence of this virus or these variants. And we don't really know how it's changing and where it is spreading as it changes. And we're also realizing, and this is a good thing and a bad thing, we're realizing that many of the surges that we're seeing in India, and this is replicatable around the world. So India is a good example right now. This is not unique to India. We see these surges, and many of these surges, for example, in India, where we're getting limited data and information, we're only seeing the prevalence about 30% or so of the variants. That means these surges are not being caused by the variant or completely by the variant. The variant could be contributing to the surge, but the surges are happening because we are not fully compliant to a number of public health measures that are put in place to slow the spread of the virus. We're not fully vaccinated, and we're not vaccinating as quickly as we need to be to get in front of the virus and the variants. And we're also still relaxing the public health measures. In India, I've seen reports of large gatherings for religious ceremonies or holiday ceremonies and other celebrations without respect to needing to be masked and social distanced. We see that in the United States too. We see governors that are eager to open their states and open the social entities, the restaurant, the bars, the businesses, and we all want to get back to work. We all want to get back to society. But if we do that recklessly and we do that prematurely in front of the science, in front of the data from the CDC and guidance, we let politics step in front of the science, in other words, and what we see time and time again is that a surge in the virus. We see a surge in the cases, which we know now leads to a surge in hospitalizations and deaths. We're still learning a lot about the virus too, though. So it's interesting. Every day for the last year, we've learned more about this virus almost every day, how it changes, how it spreads, how it affects our communities. And we're still learning the seasonality nature, perhaps, of this virus as we watch it go from place to place and around the world. And so it leads us to questions that might, that many of us probably have, and I've seen some of them in the questions coming in already. Is this virus going to go away? Is this a seasonal virus? Or how are we going to adapt our approaches and vaccines to it? And those are some really good questions that we're grappling with right now as we learn about this virus.
Okay. And so along those lines, I mean, how are we going to take these lessons learned to build a better system? So one of the questions I thought was fantastic was, how can the United States pivot away from a reactionary system and build a strong public health infrastructure that allows us to maintain a state of readiness? For decades, the cycle's been years of underfunding public health until a crisis hits. Then you get a flood of funding arriving late with stipulations to spend it down in a limited time period. This approach has further eroded public health infrastructure and the morale of public health officials. So how can this be changed? And another question related to this was, should we be more closely linking public health with emergency responders, even more than they've been before? And so, but what do you think about the public health system? How can we build back in a different way?
No, Eileen, we ask ourselves that question almost every year or every 2 or 3 years, every time there's an outbreak, every time there's a surge. We asked ourselves that when we saw Ebola emerge, when we saw SARS emerge, when we saw MERS, when we saw Zika, when we saw influenza, and now when we see the SARS-CoV-2. So we have to understand that these situations are going to continue to emerge. Outbreaks, pandemics, or viruses with pandemic potential, bacteria such as drug-resistant bacteria leading to antimicrobial resistance and sepsis. These are all endemic and potentially pandemic, and tsunamis just waiting to erupt and flood our communities. So we have to put our public health infrastructure first and invest in it, and not a one-time investment where we like panic and then neglect and panic, neglect. We overspend. Right now, we see lots of money coming forth to address this. And then once we address SARS-CoV-2, we'll see everything dry up again and everything down-regulate. And we'll find ourselves in the same situation with dry river stream when we have another virus emerge or a bacterial or fungal organism. So we have to build and sustain a public health system to stop these pandemics, to be able to respond to other major health crises. I think it's going to take three things: some really solid action plans. And these action plans have to include all of the relevant stakeholders. As you said, the public health officials, the frontline healthcare workers, the emergency response organizations at the local and at the state and at the federal and the tribal and territorial levels. We must have these action plans that are inclusive of all of the different communities at all levels to be able to know their role and be able to respond very, very quickly when we need them. We also have to have advocacy and public education. What's really amazing to me is how in our country, I'll use an example, we have over 330 million people, but yet we rely on such a handful of emergency responders or public health officials to respond to such an outbreak or a pandemic. I believe with innovations and the tools that we're developing for this pandemic and beyond, we will be in a better position to be able to empower individuals. So in the future, we could have 300 million or more first responders. If we allow ourselves to learn and be empowered by those tools, and as scientists and doctors and first responders in our community, we find ways to educate and communicate with the individuals and the public in a more effective way. And then the third thing is, I don't think we just plan it and put a playbook together and we put it up on a shelf. I think we really have to practice. We have to drill. And this is something I saw acutely. And I was in the government for nearly 10 years at the CDC, another 10 years in HHS department in BARDA. And we had periodic drills that might be at an office level or a department level. Once every blue moon, we'll say, we would bring together the states and the locals and a few and practice it, but then we just put it on the shelf. But there are things such as America has a National Preparedness Month. It occurs every September. We could expand that to be more active, and we can include schools and workplaces and government agencies at all levels. And then we can drill every single year how we would respond and how we would work together, how we would communicate in these types of events, because trust me, they're going to happen more and more frequently. And all of us who are, spending 20 to 24 hours a day, seems like 30 hours a day responding, we may not be around next time. We may not be in position that we are today. There'll be a new group of folks. And if we're not transferring that knowledge and drilling that knowledge, sort of like giving ourselves an annual booster shot for a vaccine, but a booster reminder and bringing in the next generation, then when this next epidemic or pandemic occurs, we could very easily find ourselves back in that same situation we found ourselves in last January, February, where there wasn't a plan and no one knew what to do, and we had to reinvent the wheel while the pandemic was spreading.
So I want to go to all aspects of pandemic response have been actually stifled. This is one of the questions from one of our audience. I've been stifled by misinformation. So how do we as a nation structure pandemic response in the future to mitigate false information?
Well, the false information and the misinformation are a big problem, Eileen. I mean, so we have not only a pandemic on our hands, we have an infodemic on our hands. And honestly, this type of information is killing people. We have a lot of stories, a lot of news out there that are false narratives that want to lead people to believe that the vaccines aren't safe or effective. When I tell you, trust me, I fought for this. I fought for the science. I fought for the data to make sure that the processes were led by scientists and not politicians, and that each of the scientists at the FDA and the CDC, the NIH and BARDA and others were at the forefront of developing those vaccines. So I can tell you very clearly that all the vaccines that we have now that have been authorized for emergency use by the FDA are safe and effective. I mean, however, that doesn't change the fact that we are plagued right now in a world of misinformation and incomplete data. So I'm going to put a little plug in for the Rockefeller Foundation. I'm very proud to be a part of now, but we believe that getting access to this real-time accurate data is key to ensuring that we never face another pandemic. We have to combat misinformation with facts and with data and with communication and transparency. And so there are a number of initiatives now led with agencies in the US government, the Rockefeller Foundation and others to replace or fill in those gaps to try to combat misinformation and this infodemic that is on our hands.
And so I'm going to ask you a final question, then we're going to go to the live questions. But you talked a lot about preparedness and taking the lessons learned of how could we respond better. But let's talk about prevention. Is there any way that we can actually prevent another pandemic?
I was hoping you would ask me that, Eileen. We can. I mean, I believe, and that is why I've joined the Rockefeller Foundation to launch an initiative, a new initiative, developing a pandemic prevention institute. I believe that the data out there, and if we are data-driven, that we can stop an outbreak within the first 100 days, regardless of the pathogen or where it comes from. It does take some really interesting ideas and some really hard work and a focus. I mean, we've seen in this pandemic that in many places, politics overruled science. We saw a lack of transparency. We saw limited sharing and certainly not timely sharing of information. That is why I believe if we focus on data and be data-driven, a global independent pandemic prevention institute would be an insurance policy against another COVID-19. Right now, there is no major system or entity in the world that can track and analyze data from public health and private sources, the private sector and the public sector combined, and transform that into what I call actionable information for every stakeholder, and even for individuals to know what's coming their way and what they need to do about it so they can reduce their risk and try to reduce the transmission of a virus or pathogen that might be spreading our way. The other key is it has to be equitable. One country or one region or one organization cannot control and tweak out the data slowly for whatever priority or whatever incentive that comes their way. As we build an institute that has information, knowledge, and data that we can analyze and assimilate and aggregate in unique ways now with what we have with artificial intelligence and ways of building novel algorithms and merging different types of data together, we have to make sure that that data, that information is translated so everyone can understand it and it's available to everyone at the same time. That, I believe, Eileen, is one of the surest ways to get in front of an outbreak. The second part, though, I've talked about an early warning system. We also have to have the early response systems in place. That is what's been great leading into this pandemic. We have vaccines now, which is remarkable because of the investment into platform technologies for vaccines. And then we have these international organizations such as CEPI and the COVAX organization, part of the WHO and others ACT Accelerator. And CEPI then has a same 100-day goal to respond to the halt the pandemic. So through our Pandemic Prevention Institute to get an early warning signal, where we can translate that into actionable information so public health officials can warn individuals and implement public health measures. We can also trigger CEPI and the vaccine, the private sector, and the manufacturing capability and the scientists around the world to start working on the drug and the vaccine and diagnostics. I believe if we can bring this all together, we can stop a pandemic from ever happening again.
Yeah, and I think the role for, I mean, what we're seeing, the role for local and local, state, and federal officials is the see something, say something on a disease outbreak. I mean, it was actually a company in Canada that actually first saw the issue in Wuhan by looking at productivity, absenteeism in a factory, Google searches for medicines, hospitalizations. So local officials may actually see that first and be able to sort of contact these early warning data aggregators who can then take it and say, okay, and then also put resources on it I know you're in charge of genomic surveillance. So actually looking at what is this disease, sequencing the genome, looking at, is this different? Is it new? Is it potentially much more contagious? Things like that. So the role for local officials is huge in preventing the next pandemic.
You may be surprised. We may be surprised about the types of data that actually give us the information, the signals that something unusual is happening. It's not always a virus sequence information or an outbreak, a fever, or a rash or something that gives us those signals in a community or a country that something has happened. We can look at travel data. And I think that's what we were seeing, or the Canadian group was seeing, was a lot of travel coming out of parts of the world that was unusual in terms of travel patterns. And so you can track back different types of data sets. And the power of building an institute such as the one I've described is you can bring together a variety of those disparate types of data, and you can merge different types of data that can be really powerful in telling you that something unusual is happening, and that something unusual is impactful, that you can actually focus some additional interventions in those areas and get more information, and that might be the viral or bacterial sequence, et cetera. And then you can use that in a powerful way to say something's emerging. We also have to remember in many parts of the world, not everyone has as easy access to a clinician or a healthcare provider as we see in the United States. So there are a number of efforts now to look in the community, such as wastewater and environmental sampling, that can give us some really strong signals now that something novel is emerging, some novel pathogen is emerging in the community, simply by looking in the sewer system or the wastewater systems and being able to collate those signals and then tie those to things more relevant on the ground and give us some really strong information that something is happening that we need to look more closely at.
Yes, thanks so much. So Don, why don't we go to the next thing? And I know when we talk about data, a lot of times it has red alarm bells going off for people. One of the things we're also looking at is how do we anonymize that data so that it doesn't invade people's privacy, but can still give us the signals we need. So Don, I'll hand it over to you for live questions.
Thanks, Eileen. Dr. Bright, we have a series of questions here from viewers, recognizing that we don't know everything yet, but really seeking advice for themselves, their agencies, their jurisdictions. How can they look for information about the need for vaccine boosters and the endurance of any protections that might be there now? Recognizing we might not know the answers, where should they look for that information in the weeks and months to come?
Well, the primary source of that information is going to be the CDC website. However, a lot of that information is still pending. I mean, remember, we just started vaccinating people in the clinical trials with these vaccines about this time last year, or maybe a little bit later, still in June or so. And so we're getting information as we go along, but the information we're finding so far in terms of durability or how long the immunity lasts is very encouraging. I mean, initial days, we would say it's just for a few months, and that's because we just had a few months worth of data. But we're seeing now that the immunity can last many months and maybe even up to a year. It might be very similar to the type of duration of immunity we see from influenza vaccines. But we're also seeing, Don, that the viruses are changing as influenza viruses change. Some of these variants are emerging and some of them are becoming more prevalent and sort of taking a greater role in the world and the community than the original virus that was used to make the vaccines. And so a lot of science is going into evaluating the immune response raised by the vaccines and by prior infection of the virus to see how well that immunity will still protect you from many of these variants. Now, we had 3 or 4 predominant variants over the last several months. And the good news is that the 3 vaccines that have been authorized for use in the United States have a really good level of cross-reactivity or cross-protection against those predominant variants so far. Now, it doesn't mean that you won't get infected with the virus. You might have a low-grade infection, and the immunity or the protection afforded by the vaccines may not prevent you from getting infected. But what we're seeing, which is most encouraging, is they will still protect you from getting hospitalized or getting a really serious illness and protect you from dying. And that's what you really want to see from any vaccine, is to keep you out of the hospital, keep your family members out of the hospital, and save your life, keep you from dying. And we're seeing that in each of these 3 vaccines, actually. Now, it doesn't mean that the virus won't continue to change. We might see either a combination of, as we get a year out from the initial inoculations, some waning immunity that doesn't require or at least encourage another shot or a booster of that vaccine. And it doesn't mean the virus won't change in some way that we really will have to give you a booster shot. And that booster shot might be another dose of the same vaccine. Or what's really remarkable from the technologies we're using now to make the vaccines is the vaccine manufacturers can use their synthetic technology now to make a new vaccine against the new variant that's predominating. And the booster shot might be from this new vaccine or it's the same type of vaccine, but it's a little different composition in there that will allow your body to create a stronger immune response to that variant. Some of these vaccines against these new variants have already been made, and some are already entering clinical trials. The vaccine manufacturers have also already started in the clinical trials, enrolling individuals who received 2 doses of the vaccine in the first clinical trial and giving them that 3rd shot of the vaccine. So we'll get additional information on how much immunity it boosts, how broadly reactive that immunity is, and if there are any side effects that are of note that we just want to make you aware of as you consider getting that 3rd dose of vaccine. So a lot is still to be learned, but honestly, Don, everything I've seen to date is encouraging. It encourages me a lot. And I'm really encouraged by the science behind it and all the scientists who are working diligently to try to stay in front of this so we don't find ourselves flat-footed once again.
Dr. Wright, several questions here from folks, policymakers at the local and state level who are trying to decide whether to mandate vaccines, and folks struggling to understand the difference of the current EUA status and how that might evolve. Could you just walk us through where we're at now on the 3 primary vaccines and how that might evolve into a more finalized approval for use?
Well, the data have been collected for the 3 vaccines. And actually, I think one of the vaccine manufacturers may have already submitted their data to the FDA for review for consideration of full licensure of the vaccine. So as you've mentioned, Don, all 3 of these vaccines, the Pfizer, BioNTech, the Moderna vaccine, and the Johnson & Johnson vaccine are right now being used under emergency use authorization. And that is great. And that gives us an opportunity to collect more data and to look at more. And what they're looking at too is more of that long-term safety. You know, it's one thing to have safety after 2 weeks or a month after receiving 2 doses of vaccine. It gives us much more confidence if we look 6 months or a year after receiving the first vaccinations, that there's no long-term safety concerns to be worried about. And thankfully, that's what we're finding. There isn't a long-term safety concern right now that has emerged. And that is the additional data set in most cases that will be submitted to the FDA, along with additional information on the reproducibility for manufacturing, the robustness of the manufacturing process, and some of this information on durability and longevity of that immune response, because that type of information will go into the final licensure, the label for that vaccine. And it's really important that we have that as we license or consider for licensure of the vaccine. One additional piece of data we're collecting right now is additional information on the vaccines and their safety and effectiveness in the younger populations. So right now, most of the vaccines are authorized for 18 and above. I think the Pfizer vaccine is 16 and above. And we really are wanting to include additional information for a younger adolescent population. That's going to be really important as we consider vaccinating the younger population to be prepared to go back to school this summer and this fall as well. So all of that stuff will roll into a license. So in the meantime, you touch on a very interesting topic of mandatory vaccinations. It's a very difficult conversation because, number one, it's difficult in some cases to mandate a vaccine that hasn't been fully licensed. Although a lot of that information is left up to individual, or those policies or decisions on whether or not to mandate a vaccine at that level is left up to companies or the local level or the state level. They can make those decisions. Generally at the federal level, and I can't speak for the administration or their policy or their considerations, but generally we wouldn't expect to see a mandatory vaccination policy for a vaccine, especially that's under EUA. We might see some additional discussions once the vaccines are licensed, but it doesn't prevent the discussions at the local level, at the company level. I mean, I could imagine there are scenarios in different workplace settings where employers would want to consider or are considering, I know, whether or not to mandate vaccination for their employees to protect their employee community. We've heard about discussions about mandatory vaccines or mandating vaccines for travel, for example. And again, I'm finding, and we're all finding that that's probably not the best policy. And it brings up more questions and more concerns than it does probably the issues they're trying to solve. There are people, you know, who can't take a vaccine. The vaccines are not indicated for everyone. And there are people for various reasons, maybe religious reasons or other personal reasons, cannot or do not want to take a vaccine. So in consideration for any type of policy, whether or not they mandate a vaccine or not at the local level, it's important to consider those exceptions and have a policy or have a reasonable waiver in place to be able to accommodate those individuals, whether it be enforcing mask wearing or other type of public health measures to ensure that person's safety and the safety of those around them. But I can imagine that those are discussions ongoing right now at many levels across the country and across the world. And there really isn't an easy answer or a clear-cut answer. And it's even harder, as you mentioned, because the vaccines are still under emergency use authorization. It might become a simpler topic once they're licensed.
Thank you, Dr. Bright. Eileen, actually a series of questions here for you as one of our communications leads. Any lessons learned globally from how we talked about COVID-19 with the public, with policymakers, that we might think about moving forward so that we don't battle misinformation as much as we have at every juncture during this response?
Yeah, I mean, I think one of the things is that we really are going to have to create a better system for public health officials, one that is also cognizant of the feedback loop from the public. I think we often have a sort of top-down system that's based on old communication methods, and we need to be constantly monitoring. I also think we need to work with media companies, social media companies. One of the things we're looking at on a global scale too, because a lot of misinformation is not we separate this misinformation from disinformation. Disinformation is sort of usually by a bad intent, and misinformation is something that's just a mistake, confusing, but can go, can really go viral and can get way ahead of the public health officials. So number one, the public health officials need to establish a feedback loop. Number two, they need to sort of be always scanning what's out there and have a response network, as well as alerting social media and media companies that this misinformation is out there and how to correct it, and correct it in a repetitive fashion. And I think thirdly, the other thing is to get out faster. And even though we don't know everything, we've talked about the fact that with risk communications, yes, you can say, I don't know, but what you do know is that, we know that masks will help. We know that social distancing will help. We know these things definitely have an effect on the transfer of the virus. And so I think we have to speak with one voice, and I think everyone has to speak with one voice. The other thing that we've done a lot of studying is that making sure that people have the right incentives for their behavior, so that they understand this isn't just about doing this for you, it's about doing it for your community, and it's about doing it to protect other loved ones. And so that, I think, is another critical thing. But we're really looking at, we're actually going to be investing in a lot of research to see, what do people see from information, and then what's the relationship to how do they act, and where is there a way that local officials could sort of get ahead of this and affect behavior, even if someone's seen misinformation. And it's something that we're going to be also working with policymakers as well as social media companies to see what can they do, and what can journalists do to be driven by the data and the facts, and especially around public health. It's science-based. We should stick to the science.
Dr. Bright, I think we have time for one more question, and I'll pose an expanded version of the question I just threw to Eileen. Lessons learned across the paradigm of public health policy within the US and really globally, things that we already know now that will inform better and maybe more timely decision-making for the next pandemic we'll face.
Well, Don, we're still learning lessons in this pandemic. And so the most important thing that we've learned, I believe, is a need to act early, to be transparent, and to communicate from the earliest days, to share information and knowledge. And again, these are not novel concepts. I would say the lessons that we need to learn from this pandemic are very similar from lessons that we've needed to learn from all the other outbreaks in the past. The challenge that we have isn't tabulating lessons learned or lessons to be learned. The challenge we have constantly is implementing those and actually learning and making them part of a daily life, a daily routine, so we are better prepared, we are better informed, and we can better respond when these events happen. So we can talk about the need for early warning. We can talk about the need for sharing information amongst different countries and around the world, sharing viruses, sharing samples. We can talk about the collaboration needed, country to country, company to company, and local level to federal level, and person to person. But the lesson that we need to learn is we need to learn the lesson and not just talk about them. We need to implement them. And every one of us, I mean, I'm so impressed by the participation and the breadth of experience on this call alone. And if we all find that way to not just get through this pandemic, but to codify these lessons in the connective tissue and build that muscle around them and sustain it, then working together, I'm confident that we will be in a much better place when this happens. However, lessons learned have taught us in the past that we don't do that so well. We kind of forget it. We are lucky, feel lucky to be alive. We feel lucky to survive it. The money dries up and we find ourselves going right back to complacency and right back to inadequacy in almost everything. So I would challenge everyone on this call to find ways to work together. And it starts with you. It starts with the person next to you in your office, in your organization, and then it just expands outward beyond you, beyond your organization, beyond your, if it's a tribal or territorial or local or state, into that federal level, into the community level. Make those connections and take it upon yourself to build that connective tissue and be part of the solution, be part of the lesson learned this time, so we can all be better prepared when we see this type of event happening in the future.
And I would just add to that, Rick is absolutely right, but also the private sector. The thing that we've learned in this pandemic, the private sector has really said, we really are all in this together and we need to help and innovate and work with government and work with local officials. And, you know, we've seen this time and again, businesses reaching out and saying, how can we get people to get vaccinated? What can we do to help local officials in terms of masks or social distancing? And you've seen it with the private sector. But I think that's another way that, you know, another part that we need to really pull into this preparedness and prevention.
I'm going to second that, Eileen, before we run out of time, because yes, we have seen a phenomenal level of innovation in this pandemic and collaboration from the private sector with private sector. What others might be considered or would have considered competitors have come together as colleagues and collaborators. And that is why we have the vaccines and tests and therapeutics and countermeasures that we have today, because of the private sector stepping up to the plate, because of the entrepreneurs across America and across the world lifting up the garage doors and bringing out the best science and taking risks to move it forward as quickly as possible. That is why we are now in a position to get the virus under control as quickly as possible.
Dr. Bright, thank you for those comments. Eileen, thank you again for moderating our discussion, and certainly a thanks to Tim Manning again, who had to step away, but we appreciated having his remarks at the top of the hour. And a final thank you to our co-hosts at ASTHO, IAEM, NEMA, the CHDS Alumni Association, and the Naval Postgraduate School Alumni Association Foundation. We appreciate everyone joining us today.